Welcome to Pathology Pebbles. Today we're discussing Malaria Part 2 Clinical Features and Morphological Diagnosis. In Part 1, Introduction and Life Cycle of Malaria is already uploaded into the channel. If you haven't seen it, first watch that video and secondly, watch this video. And if you like the videos, if you like these Pebbles, please subscribe the channel for more such Pebbles, like and share. And if there is any query, kindly comment and you can increase the speed to 2x as per your convenience and to save the time. Now, moving on to the, as we already discussed introduction and life cycle of malaria, part 1 link given below. Now, starting with clinical malaria. What is clinical malaria? Clinical malaria is characterized by paroxysm of high-grade fever along with anemia and splenomegaly. Clinical malaria is most common cause of the splenomegaly in developing countries. There are 3 stages of malaria paroxysm. First is cold stage, which is last for 20 to 1 hour. It is characterized by sudden onset of fever, shivering and extreme cold. Followed by hot stage, which is prolonged up to 4 hours, 1 to 4 hours. It is characterized by maximum fever with severe headache and body ache. While third stage is sweating stage, which is last for 2 to 3 hours and it is characterized by profuse sweating and temperature falls. So these are 3 stages of the malaria paroxysm. As we already discussed in first video, that in tertiary malaria like P. vivax, P. falciparum and P. ovale infection, this fever episode recur every 48 hours, while in Plasmodium malaria infection, the fever is recur in every 72 hours. So it is called as a quatern malaria. So P. vivax, P. falciparum and P. ovale is tertiary malaria, while P. malaria infection is a quatern malaria. Now moving on to the why anemia develop in a malarial patient. So anemia usually results from a destruction of the parasitized red cells, and also there is suppression of the erythropoiesis in bone marrow and immune hemolysis. So there is development of the dyserythropoiesis. Also severe intravascular hemolysis occur in a severe falciparum malaria. It is one of the complications of falciparum malaria, black water fever. Now moving on to the summary of all malaria. So main differences between all the malaria is compared in this table. It is really helpful for quick revision. So starting with the main differentiation between the all the malarias. So we will remember as a P. vivax and P. ovale. This both affect the young RBCs, and it is also these both are associated with relapse as a due to the presence of the hepatic hypnozoid. Another difference is while P. falciparum is affect the RBCs of all ages, so there is chances of severe malaria, while P. malaria affect the all RBC. Another is cytoadherence property is seen in a P. falciparum malaria, and mainly CNS involvement is seen in a P. falciparum malarial patient. Another terminology is algid malaria. So what is algid malaria? It is a severe malaria which characterized by development of shock. There is low blood pressure, cold extremities, hypoglycemia and acidosis. As we all know, most severe form of malaria is P. falciparum malaria. So it is associated with 2 complications. First is cerebral malaria and another one is second is black water fever. According to the WHO, cerebral malaria is severe P. falciparum malaria with impaired consciousness persisting for more than 1 hour after the seizure. Another one is black water fever. There is presence of black urine in malaria and it is due to the massive intravascular hemolysis, often seen in a patient treated with quinine, mefloquine and halofentrine, and risk factor is G6PD deficiency. About black water fever, there is a Pebble present on a YouTube channel. Kindly watch it. Now moving on to the When we call severe malaria, so if there is a presence of any one of the following clinical or laboratory criteria with P. falciparum malaria. Either patient present with impaired consciousness, multiple convulsion, respiratory distress, circulatory collapse or shock, clinical jaundice, along with dysfunction of the any other vital organ, abnormal bleeding, etc. Now, moving on to the morphological diagnosis of the malaria. So, there is a various method of the malaria. Clinical diagnosis, microscopic examination of blood smear, rapid diagnostic test, serological technique, and detection of malaria parasite by polymerase chain reaction PCR. The most commonly used and fairly rapid and accepted method for diagnosis of malaria is microscopic examination of the stained blood smears. It remains the gold standard for diagnosis of malaria. Blood smear should be obtained before the next episode of the fever or at the onset of the fever and chills to detect the fair amount of the parasite. Because immediately after the febrile episode, there are lysis of the parasitized red blood cells, and this morphological diagnosis should be done before the drugs, because drug can lower the parasitemia and we cannot able to diagnose the true grade of the malaria parasite. For ideal morphological diagnosis, there should be one slide of thick and thin smear should be met. For thick smear, a large drop of blood is collected in a center of the glass side. It is spread with a corner of the spreader slide or a stick in a such manner that it is evenly spread in a circular area. And after labeling, smears are allowed to dry in the air. And thick smear should not be fixed since it is to be dehemoglobinized. And thick smear is used for a detection of the parasite, while thin smear is prepared in a air dried and it is fixed with methanol and stained with a Giemsa stain or a Leishman stain. And thin smear is used for a definitive identification of the parasite species. And for comparison of thick and thin smear, thick smear is more sensitive as it allows examination of a relatively large amount of blood. So, thick smear is more sensitive than thin smear for detection of malaria. Now, moving on to the morphological comparison of Plasmodia. As the image shows P. vivax, it shows all the stages. So the above picture is showing ring. So there are presence of blue cytoplasmic ring, which is 1/3 of the diameter of the red cell, and one side of the ring is thicker and red chromatin is at the thinner part of the ring. It is seen in a Plasmodium vivax. And 12 to 24 merozoid arranged in a rosette-like granular appearance, it is seen in a schizont of a Plasmodium vivax. While as compared to Plasmodium vivax, Plasmodium falciparum has a delicate, small, uniform, fine cytoplasmic ring with 1 to 2 small chromatin dots. And in falciparum, only ring forms and gametocytes are seen. Multiple rings in a single cells are present. Red cell size is normal, but high parasite density is seen in a Plasmodium falciparum. In Plasmodium ovale, often all the stages are seen. There is a thick, dense blue ring with a large red chromatin dot seen in trophozoite, and in schizont, there is 8 to 12 irregularly placed merozoite is seen. While in Plasmodium malariae, it is similar to the P. vivax, but in schizont form, there is a daisy head pattern is seen, and there is a 6 to 12 merozoite is seen, which is arranged in a daisy head pattern. So most commonly in India, we can found Plasmodium falciparum and Plasmodium vivax. And mixed infection. So mixed infection is consist of both infection of falciparum and vivax. So the picture is showing P. vivax infection associated with simultaneous presence of multiple stages. So we can appreciate ring, trophozoite as well as schizont in this picture. While in Plasmodium falciparum, it is only show ring form. So there is a single stage is present. In upper RBC, we can appreciate the equal form. Whenever the chromatin is attached to the red cell membrane, it is known as a equal form. So for comparison of vivax and falciparum, in vivax there is a thick amoeboid trophozoite, schizont, gametocyte with enlarged red cells, and scoopness dot. While in falciparum, there is a parasite density and multiple small ring is present. Now moving on to the grading of the malaria parasitemia. So in peripheral smear, in thick smear, we can give grading on the basis of grade 1 if there is a 1 to 10 parasite present in a 100 thick oil emergent field. Grade 2 if 11 to 100 parasite present in a 100 film. Grade 3 if 1 to 10 parasite present in a 1 thick film. And grade 4 if more than 10 parasite present in a 1 thick film. Thanks for watching.